So what I am going to do today is give an overview of a very important topic, that is cough. You know, it's a symptom that is seen in daily clinical practice by the general practitioner. It is seen by the internal medicine physician, and it is also seen by the pulmonologist. So it's a very common symptom. And the idea would be to give you an overview of what is the importance of this topic. How do we diagnose cough? How do we stratify and classify cough into acute, subacute, and chronic? What are the approach in diagnosing the etiology of the cough? And accordingly, what approach can be used for the treatment of the cough? What's new in the cough management? What are the challenges that are faced in management of cough? And we'll also discuss managing acute cough and other and important natural methods to manage cough. So now let me start with the case presentation. This is a case where uh, we are a 35-year-old female is who has completed treatment for tuberculosis about 3 months ago. She's had a fever since the past 3 weeks. She feels a bit weak. She has symptoms of cough, shortness of breath, wheezing, and copious purulent sputum for 3 months. Now you have to put the focus on this word, the copious purulent sputum. And she has completed the anti-TB treatment in a very compliant manner. She has initially a yellowish colored sputum that is turned green and is foul smelling. Okay. And on examination, she is febrile, she's got tachycardia, and her oxygen is slightly on the lower side at 94%. And she's got reduced breath sounds in the right upper lobe, and she's got crackles in the right upper lobe, and the bilateral wheeze is present. So now the message, the clinical assessment here, you pick up is the copious purulent sputum is there. It's foul smelling, it's chronic, and therefore, it's got a severe infection there, and she's got coarse crackles. And if you look at this sputum here, this is the color of the sputum she's coughing out. So obviously, you would check again if there is if there is tuberculosis again. So the sputum is negative for TB, is negative for CB-NAT, but sometimes you can get a CB-NAT which is positive and a TB culture which is negative, particularly when there's an old TB and the DNA of the TB is still around, and the culture shows Enterobacter species. So now, what is the management? I mean, what is the treatment for this? The diagnosis here is it's with a post-TB bronchiectasis. I mean, that is a very common diagnosis we get. People who have a severe tuberculosis can land up with a bronchiectasis. She was treated with amoxicillin, clavulanic acid, bronchodilators, and postural drainage. How do you work up such a patient? I mean, have a look at this X-ray. If you look at this X-ray here, you will see that there are these cystic areas in the right upper lobe. If you see here, the left side is relevant, is comparatively not affected, but here clearly see in the right upper zone and also in some areas of the right mid zone, there are abnormal areas. And can you see an air fluid level here? So these are the bronchiectasis, bronchiectatic areas which are filled with phlegm, and these need to be treated with postural drainage. So only antibiotic treatment is not the solution here. You have to do postural drainage here, drain the fluid here, make the individual to cough out all the phlegm, diagnose, have a culture report, and treat it with appropriate antibiotic. So when we talk about this such chronic productive cough, like this young lady had, the treatment is you have to treat comorbidities. What are the comorbidities that could be there? There could be underlying diabetes or any diabetes, for example. Vaccination is extremely crucial for these individuals, rather for any individual who has got a chronic disease, pulmonary disease. So the vaccination protocol that is typically followed is for influenza and for pneumococcal. So that is done as per standard, as per the recommendations. Now there you have the non-pharmacological treatment. It's an active cycle of breathing technique. Now, this active cycle of breathing technique means taking a deep breath, then taking a deep breath and making a forceful cough out, which helps to remove the secretions. But along with this, what is in patients with bronchiectasis, what really helps is the postural drainage. So it has to be done in combination with that. Pulmonary rehab is typically important. For example, if people have got a chronic bronchiectasis, they're coughing out sputum, they're losing protein, they may have weight loss. So it's really important that they do a pulmonary rehabilitation along with the postural drainage. Some pulmonary muscle strengthening exercises are also done. That's extremely important. Now, in patients who have a recurrent infections and bacterial colonization, there are several trials which have shown that long-term macrolide antibiotics such as azithromycin may be given up to 6 months. But of course, that's a different topic, and you just have to see where if your patient with bronchiectasis is coming frequently, then whether your patient is eligible for that. And of course, bronchodilators are important. This individual had wheezing, had bronchi, and therefore bronchodilators. And in patients with active infection, we avoid inhaled corticosteroids. So these people here, you can use just a bronchodilators. That could be a short-acting bronchodilators, or they could be a long-acting bronchodilators. Now, this is another individual. She is an 18-year-old girl. She's been experiencing dry cough and breathlessness for the past 9 months. She's been hospitalized for acute exacerbation of asthma. Brother also has asthma, and she was being advised spirometry, but she's not able to perform the spirometry. And what we see her in this young lady is that she has a fibrotic opacities in both the lung fields, more in the right, if you could see here, in the right mid zones here, and also here on the left side, also you have these opacities here. And when a scan is done, it shows areas of fibrosis and thickening of interlobular septa in both the lung bases. So if you look at the clinical history, there's history of exposure to pigeon. She feeds pigeons every day. So she underwent a bronchoalveolar lavage. The BL showed that there is more than 30% lymphocytosis, because whenever there is an individual who's got an interstitial lung disease, there's pigeon exposure, and there's a radiological pattern suggesting hypersensitivity pneumonitis, a bronchoalveolar lavage is useful. More than 30% of lymphocytosis supports the diagnosis of a hypersensitivity pneumonitis, and the lung biopsy was also confirmatory. What is the treatment is? You have to get them away from the triggering antigen. So that the antigen has to be removed. That's the primary treatment. And these individuals will do, are treated typically with oral prednisolone and immunosuppressive agents such as mycophenolate mofetil. These are extremely important. Mycophenolate mofetil is important in helping to keep the dose of the prednisolone lower. And of course, long-term oxygen therapy in selected individuals who have extensive disease, and pulmonary rehab becomes an important component. This is a 12-year-old female with a well-controlled asthma. She now has a new onset of dry to wet cough. She's got a post-viral following a viral infection. She's got a persistent cough for 6 weeks. She's got hoarseness, but are able to speak full sentences. No apparent triggers have been identified. She has been treated with inhaled corticosteroids, beta 2 agonist bronchodilators, oral Leukotriene receptor antagonist, montelukast. She received short courses of prednisolone as well. She's also received oral antihistaminics. She's received intranasal topical steroids, which are used for upper airway cough syndrome, and antihistaminics. Antibiotics have been prescribed for potential sinus infection. And despite all this, post the viral infection, the symptoms are persistent. Okay, she had an impulse oscillometry, which was fine. CT shows no abnormality. And what we do typically is that, in individuals who have a chronic cough, a selected patients pool which come to me, we recommend them to undergo laryngoscopy. In the past, there was a direct laryngoscopy. Now we suggest a flexible laryngoscopy, which is done under local anesthesia by the ENT colleagues. And then what it showed was pulling of secretions, and basically it was, a post-nasal drip, etc. But it was negative for her. And then, as I said earlier on, her brother also had a history of asthma. So in such individuals where you've treated the asthma well, you've done the treatment for all the, you've looked at all the reasons of cough in this individual, and you suspect would be a post-viral cough. Typically, we would treat this with oral, with symptomatic therapy, including cough suppressant syrups or lozenges, but you can't give them for a long time. So such individuals are recommended to the neurologist to look for neurogenic cough. And then an assessment was made, and then she was given tricyclic antidepressant and that led to a resolution of cough. So you need to look at the psychogenic component also in individuals with chronic cough. And as we go ahead, we'll discuss this in more details. The 35-year-old female, we had questions about the topical antitussives. So she has cough. She has been given options of what all options are available. She's probably also seen on the internet what options are available for the cough suppressants. And then she's recovering from a cold. She has a mild dry cough, which has been bothersome during the day, and she wants an advice on topical antitussives. So what information can be shared with her? So of the topical antitussives which are available over the counter, the FDA approved ingredients are camphor and menthol. People, sometimes can give inhaled camphor and menthol to stimulate the sensory neurons and create an anesthetic sensation, and that improves the respiratory airflow, and accordingly the cough reflex can be suppressed. But although it is generally well tolerated, it can lead to a burning sensation of the eyes, nose, and the skin. In this scenario, the lozenges are also available, and these lozenges of these formulations are can be very helpful. They dissolve slowly in the mouth. They are not supposed to be bitten, and as it forms a coat, a demulcent coat also over the throat, it helps in the reduction of the cough severity. Typically, if these individuals are having cough, I mean, like you said, this she's able, these individuals may be able to talk long sentences, but I think if it is affecting their work or if it is affecting their meetings, etc., in day-to-day time, yeah,